We looked at the life cycle of influenza virus and the mechanism of action of antiviral agents used for treatment of influenza. We looked at the complications of influenza such as secondary bacterial pneumonia. We developed a patient-specific plan for prevention of pneumonia. Now the last learning objective is develop a patient-specific plan for prevention of influenza. Since 2010, annual influenza vaccination has been recommended. Influenza vaccines are either trivalent or quadrivalent. Trivalent has 3 strains, 2 strains against influenza A and 1 strain against influenza B, typically the Victoria lineage. Quadrivalent vaccines has the 3 strains that are in trivalent as well as 1 additional strain typically against influenza B Yamagata lineage. This year for the 2020-21 season, 3 of the 4 strains have changed compared to last year. So you can see for influenza A, strain 1 and 2 have changed compared to last year. And also this year, it depends on the formulation. So for the egg base, you can see that we have a different influenza A strain for H1N1 compared to the cell cultured and the recombinant one. So those have different strains of H1N1. And then for the H3N2, you can see that although regardless of the formulation, we have the Hong Kong strain, but there are different strain numbers, so they're slightly different. For the influenza B, the Victoria lineage is the same for the formulation, but it is different compared to last year. So last year we had the Colorado strain, and this year we have the Washington. And for influenza B Yamagata lineage, the Phuket strain remains the same as last season. Routine annual influenza immunization is recommended by CDC for all persons aged 6 months and older who do not have contraindication. Now, there are a lot of formulations on the market, and the CDC does not have a preference for any of the formulations. So as long as someone does not have a contraindication, they should receive any of the available formulation. The reason is if the CDC prefers a specific product, should your inventory be out, then you lose the opportunity to vaccinate people. And the CDC wants to vaccinate as many people as possible. Ideally, patients should be vaccinated by the end of October, and vaccination should continue throughout the flu season. For people who get vaccinated early on, revaccination later in the season is actually not currently recommended. And it's important to keep in mind that it takes about 2 weeks for vaccines to be kicked in. So it's important to be vaccinated by October, just as the flu season is about to start. Now for children 6 months through 8 years of age, specifically we want to optimize protection. So if it's the first time a child is getting influenza vaccine, it's actually recommended to administer 2 doses, and those 2 doses should be at least 4 weeks apart. So you keep the first shot and then at least 4 weeks later you give a second shot. Now if a child has only received 1 dose previously in their life, you should still give 2 doses, of course 4 weeks apart. Now, if a child has received 2 doses in their life before, and those 2 doses do not have to be in the same season, so they can either be 2 doses in the same previous season, or they could have been 2 doses on 2 different years previously. In that case, that child only needs 1 dose. Here are the currently available influenza vaccine formulations. Note that the only available live attenuated influenza vaccine is the FluMist, which is a quadrivalent vaccine, and it's only recommended for patients aged 2 years through 49 years. Now, for 2 years in a row from 2016 to 2018, FluMist was actually not recommended due to poor performance in the previous years. And then starting 2018, it actually came back to the market because we didn't want to lose the opportunity to vaccinate specifically children who may not be able to get injection, and also for patients who were afraid of injections. Now, because of the poor performance of live attenuated influenza vaccine compared to inactivated influenza vaccine, it's only recommended for patients 2 years of age through 49, because those who are younger than 2 years and those who are older than 50 years are actually high risk for influenza complications. So for those patients, we actually want to give a more efficacious vaccine, which is inactivated influenza vaccine. Now, when it comes to inactivated influenza vaccine, the vaccines are typically either a standard dose or a high dose. And the majority of the flu shots that we give to the population are the inactivated standard dose. Now, for the inactivated influenza vaccine at the standard dose, we have 4 different brands on the market. The most common one that you will see used is the Fluzone. Keep in mind that these are all only available as quadrivalent. And as of last year, all of them are indicated for age 6 months and older. Now, a couple of them, the dose may be dependent on the age, so please consult the package insert before you administer it to your patient. There is also a cell culture formulation, which is Flucelvax. And what's different is that, Flumis and all the inactivated influenza vaccines are actually grown in egg. So they actually use hen egg to grow these vaccines. And some patients might actually have egg allergy. So if they have actually consumed egg and they had a allergic reaction to it, those patients are considered egg allergic. So these vaccines that are grown in egg may actually include proteins from eggs. So in order to avoid that, we actually have cell culture. So instead of growing it in egg, they actually grow it in mammalian cells. So that's where the cell culture comes in. And we only have one formulation on the market, which is Flucelvax, and it's only approved for age 4 years and older. Alternatively, we have recombinant influenza vaccine, which actually uses recombinant DNA technology. So it's not grown in any cells, not in eggs and not in mammalian cell. So that's actually approved for age 18 and older. So it's not approved for use in children. Now, when it comes to older patients at age 65 and older, we have adjuvanted inactivated influenza vaccines, so Fluad and Fluad quadrivalent. So quadrivalent version became available earlier this year. And then we have the high dose inactivated influenza vaccine, Fluzone HD. Now, keep in mind that the Fluad, the trivalent, this is the only trivalent formulation that exists on the market this year. Everything else is quadrivalent. I will explain the benefit of using adjuvanted or a high dose vaccine in elderly shortly. Although not common, you may come across patients who have egg allergy. As I mentioned, majority of the influenza vaccine formulations are actually grown in eggs. Only the recombinant influenza vaccine is considered egg-free. It utilizes recombinant DNA technology to manufacture the vaccine. Cell culture grown vaccine utilizes mammalian cells instead of eggs. However, some of the viruses provided to the manufacturer are actually egg-derived, and therefore egg proteins may potentially be introduced at the start of manufacturing process. So should we only give recombinant influenza vaccine to patients with egg allergies? Well, first of all, it's important to know that the CDC recommends considering patient observation for 15 minutes after administration of any vaccine, not just the flu shot. So it's important to observe patients. Secondly, if the patient's reaction to egg, not the vaccine, but if they had a reaction to the egg and the reaction was hives, the recommendation is that the patient should receive any licensed vaccine, not necessarily the recombinant influenza vaccine. So any licensed vaccine. So it could be any of the inactivated influenza vaccine, or it could be the recombinant influenza vaccine, or even the live attenuated influenza vaccine. Now, if the symptoms to egg allergy was anything other than hives, so if the patient had angioedema, respiratory distress, or if the patient required epinephrine, the recommendation is that the patient still may receive any licensed influenza vaccine, including inactivated influenza vaccine, but you should administer it in a medical setting. And the medical setting could be either inpatient or outpatient. And that's where a clinician who's trained to actually handle any of these reactions, so that should the patient have an allergic reaction to the flu shot, then in a medical setting, the clinician can actually administer epinephrine and make sure the patient is well taken care of. Now, if a patient actually had an allergy to a vaccine itself, not the egg, just the vaccine, it's actually contraindicated to give them the flu shot. One thing that you may encounter in practice is patients who are pregnant. So in general, inactivated seasonal influenza vaccine is indicated in pregnancy. Live attenuated influenza vaccine is actually contraindicated in pregnancy. So in pregnancy, you should avoid live attenuated vaccine. A pregnant patient should actually receive the flu shot, as long as the pregnancy is during the flu season, ideally either before pregnancy or during any of the trimesters. Now, although the CDC doesn't prefer any specific products other than saying live attenuated is contraindicated, it's important to know that some of the more recently licensed products are actually that we have less experience with their use in pregnancy. That includes, quadrivalent formulations are relatively new compared to trivalent, and cell culture base is also relatively new. In fact, for recombinant influenza vaccine, actually very limited data. So although those are not contraindicated, you may want to avoid them if you have the option. But the bottom line is the CDC says, if this is the last thing that you have in your stock, you should still give it to the patient. When it comes to immunocompromised patients, so either patients who are taking medications who are immunosuppressive, or if they have immunodeficiency diseases such as HIV, live attenuated influenza vaccine is contraindicated, so you should give any of the inactivated vaccines. Now, what if the patient is taking influenza antiviral medications? In general, administration of inactivated influenza vaccine as well as the recombinant influenza vaccine is acceptable. However, we have to be careful if the patient is receiving antiviral agents with the live attenuated influenza vaccine. And the reason is that live attenuated influenza vaccine actually needs to replicate inside the patient in order to have immunogenicity. So we have to make sure that during the time that the vaccine is replicating, there is no active drug in the body. So in general, it takes 2 weeks for the average person to develop antibodies to the virus. So it's okay to take any of these agents 14 days after the vaccine. However, how long before giving the vaccine depends on the agent. So for oseltamivir and zanamivir, it is generally okay to give the vaccine as long as 48 hours before the vaccine the drugs have been stopped. However, pramivir and baloxavir have significantly longer half-life, so it is recommended to give the vaccine 5 days after pramivir has been stopped and 17 days after baloxavir has been stopped. Now, when it comes to elderly, age 65 years and older, the issue is that the antibody titers actually decline a few months after immunization. And that's because, as we get older, our immune system doesn't work as well. Now, the recommendation of CDC is that any age-appropriate inactivated influenza vaccine should be acceptable option for elderly. So either standard dose or high dose, either trivalent or quadrivalent or unadjuvanted or adjuvanted, or recombinant influenza vaccine. And that's because they want to vaccinate as many people as possible. So anything that you have is an acceptable option for elderly, with the exception of live attenuated vaccine. So live attenuated vaccine is not recommended for anyone age 50 and older. So we do have the high dose inactivated influenza vaccine, and we have a study that they actually compared the high dose to standard dose. And we found that there was a 24% greater relative efficacy with the high dose. So, although CDC doesn't have a preference for it, if you do have the high dose, those elderly patients would actually benefit from the high dose compared to standard dose. But if you're out of the high dose, you should not ask the patient to come back when you have the high dose, because the CDC says that, if you have the opportunity to vaccinate people, you should do it on the spot, because there is a good chance of losing patients to follow up. So if you ask the patient to come back when you actually have the high dose, there's a good chance that they're not coming back. So while they're there and you have the opportunity to vaccinate them, you should vaccinate them with any formulation that you have. Now, with the recombinant influenza vaccine, we actually saw a better response in patients who are elderly. So in the subgroup of patients who had 65 years of age and older, there was actually 17% higher efficacy with recombinant influenza vaccine as opposed to the standard dose inactivated influenza vaccine. The point of adjuvanted influenza vaccine is to actually boost the immune response to it. So we do use substances that actually are immunogenic. So MF59 is a squalene-based oil in water emulsion, and it actually acts by both recruiting antigen-presenting cells to the administration site and also by increasing the binding strength of the antibody to the influenza virus, which results in a more efficient antigen uptake, processing, and transportation to the lymph nodes. And in studies, we saw a 63% greater relative efficacy in elderly patients. So again, although these are nice to give to elderly, you should give the elderly any formulation that you have in stock. This concludes this presentation.